Please, there we go. So please modify your name or shut off. I guess your videos are shut off anyway, but just modify your name if you do not wish to be recorded. And we also have all of you muted so that there won't be any interruptions. So at the end, well, actually all throughout the talk, the Q&A feature is how you can ask questions. So please put your questions in the Q&A and we'll have some good time for questions and answers afterwards. Also, the session will end about 10 minutes before the hour to allow for a break until the next session. So thank you again. And without further ado, I'll introduce Dr. Turner-McGrievy. She's an associate professor at the University of South Carolina in the Department of Health Promotion, Education, and Behavior. She's also a deputy director for the Tech Health Center at the Arnold School of Public Health. We're thrilled to have you here today, Brie, and it's all yours.
Great, thanks so much. I'm really excited to be talking to everyone today. So I'm going to be talking about behavioral strategies we've used for facilitating adoption of plant-forward diets. So I'll walk you through a little roadmap of today's talk. So I'll start with some trends I've seen in plant-based eating over the past 2 decades. I'll provide you with an overview of 3 of our research projects that focus on plant-forward eating. And then I'll talk about 6 behavioral strategies that we've used to facilitate adoption of plant-based diets. So I started working in the area of plant-based nutrition over 20 years ago. And during that time, I've seen lots of changes in the nutrition landscape around plant-based eating. So some positive things that I've seen. One, increased availability of plant-based options in stores and restaurants. So a lot easier to find a variety of different plant-based sources of food throughout different stores and eating establishments. And also an increased interest overall in plant-based diets for prevention and treatment of chronic diseases, and just a general interest in the focus on sustainable eating patterns overall. But also some negatives too. Over the past couple of decades, there's been an increase in sort of availability of highly processed foods, not just sort of plant-based foods, but every kind of food. And it's hard to really make money off of beans and rice. So food companies find a way to sort of market plant-based foods, but they end up being somewhat processed. And I think a lot of what's driving that is there's been just a decrease in foods prepared at home and just a general lack of cooking skills. So when we first started doing our interventions, our work would really focus on teaching people new ways to cook, not cooking skills. And so over the 2 decades we've been doing this work, we really find that we're having to start from scratch with a lot of our participants, teaching knife skills and how to saute and how to roast vegetables and, some basic things that we didn't have to cook before. And, we've seen this sort of increase over the past couple of decades where the amount of food eaten away from home has been increasing. And so there's really been sort of this, generation of folks that have forgotten the skill of cooking. So the goal of today's talk is to provide an overview of behavioral strategies used to facilitate adoption of plant-forward diets in 3 different community-based interventions. So our team has conducted research with many different populations, but today I'm going to talk about 3 of our more recent studies, and these were all conducted among African Americans living in the southeastern US. So first I want to introduce our team because this is what makes all the hard work go off seamlessly. So recently our team leaders kicked off our colloquium series for our health promotion, education, and behavior department. So thought I could use this little flyer to introduce us. So Dr. Mary Wilson is our lead project manager of our study, and she also is the director of workforce development now for our School of Public Health. Dr. Carolina Delgado Diaz is our project manager for our mobile lifestyle intervention for food and exercise study. I won't talk about that study today, but I will put the link for that study at the end. It is an all remotely delivered weight loss intervention. anyone in the US can participate. And so if you know of anyone that's interested, we are currently recruiting for that study. So I'll have that study link at the end of the presentation. And then Dr. John Bernhardt is a research assistant professor in our department and also heads up our New Soul dissemination implementation study, which I'll talk about today. Also have great doctoral students who work on all our projects, and we're always looking for good students. So if any of the students out there are interested in getting a PhD or master's degree in public health, particularly around health behavior and nutrition, then certainly reach out to me. And then our wonderful staff also who helps make all our projects work very well and help us with recruitment and retention and all the nuts and bolts of our research. So I'm going to talk about 3 of our studies, New Soul Diet Guidelines 3D study and New Soul D&I. So I'll start with our Nutritious Eating with Soul study. So the purpose of this study is really to focus on the fact that we know that African Americans have the highest rates of obesity and heart disease compared with whites and Hispanics in the US. And we also know African Americans have been very underrepresented in behavioral nutrition research. And many studies that have been observational in nature have looked at different dietary patterns among African Americans, particularly the Seventh-day Adventist cohort studies. And it found that those African Americans who are following more plant-based diets like vegetarian or vegan diets have significantly lower risks of many chronic diseases, hypertension, diabetes, cancer, high lipids, as compared to those consuming more omnivorous food styles. So the objective of the New Soul study was to compare 2 different soul food dietary approaches on the reduction of body weight and CVD risk factors. So what is soul food? So I grew up in Alabama. I live in South Carolina. You know, I'm very familiar with soul food, but I know not everyone is. So soul food is the term used to describe the ethnic cuisine that enslaved Africans prepared in the southern United States to survive during slavery. So today, common soul foods like collard greens, cornbread, pulled pork, and fried chicken, which were staples for African slaves living in the South, are still regularly consumed by both African American and white Americans living in the Southeast US. So then what is vegan soul food? What was plant-based soul food? So vegan soul food adapts traditional soul food recipes to healthier versions with lower saturated fat, no cholesterol, things like using mock meats made from plant protein versus regular meat, reliance on beans and grains, egg and dairy-free cornbread, and greens cooked without fat back. So this picture here is sort of an example of what a vegan soul food plate may look like. So the New Soul study was a 2-year intervention, and participants were randomized to either follow a low-fat omnivorous soul food diet or a low-fat plant-based soul food diet. In the picture here with a piece of soul, that's one of our many vegan soul food restaurants we have in Columbia, South Carolina that we've worked with. So in our New Soul study, we had 2 cohorts of study participants. They went through the study 2 years each. And in our study, we had cooking demos, hands-on cooking practice, physical activity information and demonstrations and nutrition information. And then we tried to keep things fun because we're with our participants for 2 years, so we want them to stick with us. So we met weekly for 6 months, and then every other week for the next 6 months. And then the last year, the study participants met monthly. So what do the diets look like? So we try to adapt both diets to healthier versions by reducing the fat, increasing the plant-based sources. Our omnivorous diet was still relatively plant-based. We based that around Old Ways African Heritage Pyramid. But things like, for lunch in the vegan group would have like a veggie plate. So have a lot of the sides that are usually available in a lot of soul food restaurants. So some of our results, so we recently published our findings, the citations there, and you can find the citations on our website too. So participants were mostly in their late 40s, mostly female, mostly had college education, and most were food secure. And then these are our findings. This is weight loss among all our participants across the 2 years of the study. So weight loss was significant within group, but we did not see any difference between the groups. And you'll see with all of these that the vegan group through, sort of 6 months was doing well. And then we stopped sort of seeing differences after that. So this is results for total cholesterol, so sort of similar pattern there. And this is our results from for LDL cholesterol. So we did see one big significant difference, and that was weight loss by cohort. So we had 2 cohorts in the study. Our main outcomes were at 12 months, and this is the weight loss for everyone in cohort 1. So lost about 3.5 kilograms over the course of the 12 months, looked great. And they lived in a COVID-free world. So no COVID for their whole 12 months of the study. So then we started with our cohort 2. They went through 6 months, similar weight loss pattern, looks great, but then COVID came. So all of a sudden we have COVID, we have to switch to all our classes online. Our participants were under extreme amounts of, stress, and their weight went way back up. So we definitely saw, differences in terms of cohort for the study. So that did impact our overall results. We also looked at adherence and diet quality in our New Soul study through the first year of the study. And we measured adherence by looking at 5 different animal protein-based food groups. And the omnivorous group had certain goals or limitations for those food groups, and the vegan group was supposed to not eat any of those food groups. So we scored their diets based on 3 days of dietary recalls, and each group could get a point for 5 being totally adherent to 0 no adherence. So for this, we had 113 participants with complete dietary data. And we looked at diet quality using 2 different indices. One was the alternate healthy eating index. That was on a score of 0 to 90. And we used all the output that we could from ASA 24. So that's things like scoring how many vegetables they have, how much fruit, how many whole grains they're consuming each day. And then we also use the healthy plant-based diet index as well. So that is broken up into food groups, healthy and less healthy plant-based groups, and also animal-based groups. So similar to the alternate healthy eating index with a focus on fruits, vegetables, whole grains, and then also looking at animal-based food groups like animal fat, dairy, egg, fish, and seafood or meat. We used all the output again from ASA 24 that had the food groups that we could use, and the scores for that range from 14 to 70. So this is the percentage of participants that were adherent to the diet assigned at each time point. So vegan participants are actually more adherent at each time point as compared to the omnivorous diet group. And then we looked at diet quality at each time point as well. And we saw that vegan participants, regardless of level of adherence, were still had significantly higher diet quality as measured by the alternate healthy eating index score at 3, 6, and 12 months. And same finding for our plant-based diet index score as well. So some limitations of looking at the dietary adherence, we only looked at it among participants that we had diet records for, so we don't know about the diet quality of people that didn't complete their diet records. And right now we're working on a paper that will hopefully examine all our main outcomes by level of adherence. So our main outcome paper just looked at everyone, whether they were adherent to the diet or not. So we're interested in what those outcomes are for those who are adherent. So these are just some of the papers that we have from New Soul. And again, you can get those on our website too, which I'll share at the end. All right, so the next study I'll talk about is our DG3D study. So Diet Guidelines 3 Diet study. So this study is in two parts. We started with a 12-week randomized weight loss intervention and diet quality improvement among African Americans, and then used that information to refine the intervention for a 1-year study, which is what we're currently doing right now. So the U.S. dietary guidelines, in case you're not familiar with them, they form the basis of all our federal nutrition programs and policies. So right now they're gearing up for the next round of review of dietary guidelines. And they really form the basis for things like industry-related food recommendations, community-based nutrition programs, health initiatives. So they're really important. And the U.S. dietary guidelines, their scientific report, state that healthy eating goals can be met through a variety of dietary patterns, but they present 3 main dietary patterns in line with this recommendation. So the healthy U.S. style eating pattern, a healthy Mediterranean style eating pattern, or a healthy vegetarian eating pattern. So in terms of measuring how well we're doing with meeting the U.S. dietary guidelines, often we'll use the Healthy Eating Index as a metric for that. So Healthy Eating Index in the U.S. is generally low. We score it from a 0 to 100, and we average about a 59. So we're kind of failing overall in our diet. And diet quality is important because poor dietary quality has been associated with obesity, type 2 diabetes, and a number of different chronic diseases. And in general, African Americans have lower HEI scores, around a score of 54, as compared to Hispanic adults, which have a score of about 60. And among adults with type 2 diabetes, African Americans have lower HEI scores, a mean score of about 51, compared to white adults, a mean score of 55. So when you look at the scientific report for the U.S. dietary guidelines, most of the research that's informing those 3 different recommendations, 3 diet patterns that they recommend, has really been largely drawn from observational studies. So we don't exactly know what happens if people transition to one of these diet patterns. And it's also mostly among white populations. So there's been really limited research in these dietary patterns among African Americans living in the southeastern US, who we know experience a disproportionate burden of chronic disease. So our main goal with this is to look at how these dietary patterns impact diet quality and type 2 diabetes risk factors among African Americans living in the South. So the objective of the study was to test the 3 dietary patterns as presented by the U.S. dietary guidelines among African American adults at risk for type 2 diabetes. So we did a 12-week intervention, and those results are informing a 1-year trial. So for this first 12-week study, we only used materials from the U.S. dietary guidelines. So we did no cultural tailoring at all. We wanted just to use whatever, the U.S. dietary guidelines presented. We didn't alter the recipes, so we took them all from MyPlate. They have a filter on the MyPlate recipes where you can filter by cuisine. So we used American for the healthy US, vegetarian for the vegetarian group. Mediterranean, they only had 19 recipes. So we had to branch out, and we included Latin American and Hispanic as a filter as well to add some more. This was supposed to be in person, but COVID was rising at that time. And so we moved all the classes to Zoom. So participants attended Zoom classes for 12 weeks. They could come in person to pick up samples of the recipes that we demonstrated in the Zoom classes on non-class days. I have not figured out how to have Zoom be like a smell-o-vision or taste-o-vision, so we still have participants come in to taste the foods. After those 12 weeks, we then conducted extensive focus groups for the participants to help refine the intervention and culturally tailor it for a one-year intervention. So in our 12-week intervention, again, these were all by Zoom. This is Jessica, a nutrition interventionist, cooking up some tofu. So our goal in the study was to help promote weight loss among participants, but we didn't have them track calories. Instead, we used the MyPlate plan calculator to calculate a calorie goal based on their body weight, height, age, activity level, and sex. And that allowed us to give a meal plan for them with serving sizes for each of the food groups based on MyPlate. So all classes were led by an African-American nutrition interventionist and African-American registered dietitian. And all the study groups had the same sort of structure. We welcomed everyone. We then did some sharing of successes and challenges from the previous week. We did that in small groups using Zoom breakout rooms. We then did a nutrition topic directly from the U.S. dietary guidelines. Because U.S. dietary guidelines don't really talk about behavior change strategies, we adopted some of those from the diabetes prevention program. There was a cooking demonstration and then a setting of a goal for the week. So our DG3D study is overseen by our community advisory board. They're really vital in helping us come up with good recruitment strategies, retention strategies, and helping review our materials as well. So our main results were just published for this in the Journal of Nutrition, and that's a citation for that. So again, our population was mostly female in their late 40s and mean body weight of about 100 kilograms. Our hemoglobin A1C was 5.7. So a level of 5.7 to 6.4% indicates prediabetes. So our goal of the study is to prevent diabetes. So we were getting a population that, was in need of making sure that hemoglobin A1C didn't go up anymore. Blood pressure was putting participants at an at-risk hypertension level, and HEI score was 55.8, which is below the US average. In terms of class attendance, participants attended 79% of the 12 classes that were offered, and there was a significant difference in the total number of classes attended, where the participants in the Mediterranean group attended significantly more classes, about 10.6, than the vegetarian group that attended 8.1. But we did not see any difference in weight loss among the three groups. We saw average weight loss was all significant within group and lost about 2.5 kilograms over the course of the 12 weeks. We didn't see any difference in hemoglobin A1C either, although you can see the Mediterranean group was the only one that had their values go down, but none of these were significantly different. We did see some differences in HEI score. So there was a significant within group change in the Mediterranean group. And that was the only group that saw a significant improvement within group. And they were significantly different from the vegetarian diet. So they scored about 10.6 points higher than the vegetarian group. So overall, in this study, it demonstrated that participants across all groups lost equivalent of 2.6% of their body weight, which I think is pretty impressive considering this was all remotely delivered. Participants did not track calories. And when we want to try to get to a 5% weight loss by 12 weeks, we were already halfway there. So we were happy with that. So basically all three diet patterns led to significant weight loss among African American adults, but they weren't different among the three groups. So lastly, I'll talk about our NuSol dissemination and implementation study. So this is really taking what we did with our NuSol original study and disseminating it out into the community. So a lot of this work came about through formative work led by one of my former doctoral students, Dr. Anthony Cromarco, who interviewed African-American vegan soul food restaurant owners to look at their role in the community and how they promote health. So there's actually many vegan soul food restaurants throughout the southeastern United States, and often they're located in communities in areas that don't have access to healthy food. And so a lot of the work that he did and found with these restaurant owners is they really view their role in the community, not just as business owners, but really also making sure that they help promote health of their patrons. So we really saw this as an opportunity to partner with restaurant owners in a community setting. So our New Soul original study was funded by NHLBI back in 2017. Then Dr. John Bernhardt received a diversity supplement in 2020 to pilot this 12-week intervention with a local vegan soul food restaurant. And then we received funding in 2022 to test that out on a larger scale with restaurants in both South Carolina and North Carolina. So this was our rare variety study. So our restaurant partner was Keith Alexander. He was owner of Rare Variety Cafe. We asked him to identify a community health worker to deliver the classes. We wanted to not have it be, our experts that are in the university setting. We really wanted to take it out into the community. So Benita Clemens was our community health worker. And intervention, again, was supposed to be in person. It was supposed to be delivered via restaurants. So participants were supposed to go into restaurants. I think we got notice of award like right before COVID happened and realized that, not only were things not happening in person, restaurants were shut down. They were not allowed to be open. And so we switched again to all Zoom based. Benita was really great about having different camera angles. She had one that would, set on her food so you could see her actually demo in her kitchen. So that worked out really well. And then participants could attend those weekly classes via Zoom. They were able to, we gave everyone a voucher for a free meal from the restaurant. So they could go into the restaurant once a week and pick up a meal from the restaurant. So we were still able to officially partner with restaurants. So during the study, it wasn't a randomized study. It was just looking at using REAIM as a framework. So looking at effectiveness of the outcomes, we saw that participants lost 2.6 kilograms over the course of the study, and their nutrition self-efficacy also significantly increased. As part of the REAIM framework, we also looked at maintenance. So we had our participants in the study for 12 weeks, and we said, okay, we'll see you in 6 months. We're not going to do any more intervention. We just want to see what happens with weight loss after that. And we were really excited that there was no increase in weight. So a lot of times you'll see weight regain, but after 6 months, we did not see any significant increase in body weight. So participants had maintained what they lost. So these are the aims of our New Soul dissemination and implementation study. So our first aim is to look at the effectiveness of our 12-week program on body weight and diet quality among African Americans. And then we're doing a cost-effective analysis. So participants in this study are randomized to either a 12-week intervention with vouchers to our community partner restaurant, or a group that just gets vouchers only without the nutrition education. And then we're also looking at implementation outcomes like feasibility and utility. So we're just starting our first cohort. We're doing this in Columbia, South Carolina. We're partnering with Chef Judy, who is our restaurant partner in Columbia. And then we have another partner in Charlotte, North Carolina. So each restaurant will have 3 cohorts running through them throughout the next couple of years. We also have a great community advisory board that helps guide this work. This is part of our Prevention Research Center, and this is their advisory board, and part of their task is to oversee our study as well. All right, so lastly, I'll talk about strategies we've used across these 3 studies to help facilitate plant-forward diets. So some examples that we have used that we found to be effective. So obviously we do a lot of collaboration with African-American soul food community chefs and restaurant owners. So that's a big one that we do. So that helps us, connect members of our study participants with members of the community that have healthy food options at their restaurants, but also allows us to have cultural adaptations of plant-based diets that are palatable and familiar, and provide opportunities for hands-on cooking demonstrations as well. So we bring in guest chefs who cook vegan soul food cuisine or own vegan soul food restaurants to work with participants. So in the middle there is Miss Gloria Clay. She won our Columbia Vegan Mac-Off. So we had a mac and cheese cook-off. All the entries were restaurant owners except for Gloria. She was the only home chef and she won. So she comes in and demos our her award-winning vegan mac and cheese. Next is bringing in the experts. So we work with African-American experts in health, emotional eating, religion, a variety of different topic areas to address, issues that are impacting maybe what you eat, but aren't what we traditionally would think a nutritionist would maybe deliver, but things that are very specific to the African-American community. So some of the people we work with on the left here is Dr. Amente Sujai. She is professor of religion at Allen University, and she was a consultant on New Soul. And she comes in and does a really nice talk to our participants about the interplay between spirituality and religion and diet. In the middle there is Dr. Kim Williams. He's a consultant and cardiologist on the New Soul study, and he's past president of the American College of Cardiology, and he records messages that we deliver to our participants that talk about the importance of, participating in research studies and improving your diet to improve heart health. And then Tracy McCorder there on the right is a plant-based nutrition expert. She's the author of By Any Greens Necessary, which we raffle off her cookbooks all the time to our participants. So we also bring in other members of the community like African-American yoga instructors, personal trainers, African-American counselors who come in and talk about stress eating and the relationship between stress and our health. So we have a variety of different experts that come in that really talk about the whole person in terms of health. We also find community partners to help address barriers, particularly around the barriers to cost and food access. And as we know, food has gone up and up in cost, so this has been more and more of an issue. So we know that barriers to healthy eating, really include high cost of food, general access to healthy foods. So one of our main partners is Food Share in Columbia, South Carolina. So they help participants access healthy foods. They have these vegetable and fruit boxes that participants can get. The boxes are SNAP eligible, so it's $25 for a large box. But if you're using SNAP, it's only $10. And so we partner with them to allow pickups for these food boxes. One of my favorite classes we do is we have what we do as a chopped challenge in class. So we will make some staple items like grains and sauces, but then we have our participants get in a group and they get a food share box, they open it up, and they have to come up with a meal using the ingredients that are in their box, which is always fun. They come up with great stuff. We also hire community facilitators to help lead discussions in classes, particularly around the successes and challenges participants may face during the week. And so we usually have a few African-American community members come in and help lead those discussions. So this is one of the papers that one of my doctoral students, Keisha Akpara, wrote, where she did qualitative work with our New Soul studies, looking at what factors really helped with participants' self-efficacy and confidence around ability to adhere the diets that we were covering in our New Soul study. So the participants explained that representation was really important for them in following the New Soul program in their assigned diets. And they really emphasized, because the moderators reflected the participants racially and had similar experiences. So one of our community facilitators was also going through a weight loss journey, and he really talked about his struggles with that. Participants felt really encouraged and committed to follow through with the program. They liked when moderators were really open and honest about, what they were going through as well. So one of the quotes from our participants is, facilitators, like the choice of the facilitator really matters, study staff matters. Other themes that emerged in our focus groups with participants related to things that supported dietary change included just general awareness of the diet choices they were making, being in control over their food choices, family support, and being able to influence others to be healthy as well. So we also like to include many ways to provide support, and we feel that that's an important aspect of making sure that participants have numerous contact with us throughout the study. So we do things like we have podcasts that we do, videos, newsletters, particularly when we go from weekly classes that are face-to-face going through less frequent meetings, like bi-weekly meetings. We'll do things like online newsletters, private Facebook groups, virtual classes we'll hold for holidays and makeups. We do lots of texting and phone calls, and hold group community events too, like we all do a 5K or a walk together. So I'll just say we started out, a lot of my research focused on using social media to provide social support. So I've done several studies using social media as a platform to help participants connect with one another. And it started out being, pretty helpful for participants. So this is a study that we did from a study we called New Diets, and it had 5 different diet patterns among participants who were trying to lose weight. And participants could participate in their Facebook group for their assigned diet. It was a private Facebook group, and we gave them 5 different messages each week. And we altered the type, but we had the same type of message, these 5 types throughout the week: a weight loss related message, a recipe, a nutrition study, science or news item, a polling feature that asked like, what's the most challenging meal for you to prepare each day, and then a suggestion or request. So share with the group some information. And then we looked at which message type elicited the most comments and poll votes. And we found that polling was the most engaging type, followed by requests. So asking people, hey, can you share something with the group? Weight loss related messages were in the middle, then followed by nutrition, news, and recipe didn't get much action. So why is engagement important? Well, we looked at how Facebook engagement related to weight loss, and we saw that during this 4-month maintenance period that we had where we introduced the Facebook groups, Facebook engagement was significantly associated with weight loss, such that any 10 interactions on Facebook was associated with a mean weight loss of 0.43 kilograms. Now, this was about 10 years ago. And social media has really changed over that time period. We also asked participants which kind of message you actually liked the most. And oddly, recipes were the primary one that they liked, even though that did not get really any engagement at all. And no one reported liking the weight-related posts. So over this, last decade, we've really noticed a changing landscape in social media. So we've noticed a decline in participants in Facebook groups in our study. So participants used to really like the Facebook groups for interacting, and we started noticing a decline. It really was when there was all the news about Russian interference in elections that we saw this sort of drop off in Facebook participation and this increase in social media distrust. So we administered a survey to participants in our new SOL before to our cohort 2, asking them, how much do you trust social media, and found really high levels of social media distrust. So in our DG3D study and our focus groups, we asked participants, what better way would you like to communicate? And they all voted for GroupMe. So GroupMe is just like a texting platform, and they're like, we just want to communicate with each other. We don't want to see other things. And so that's what we're using now in our year-long intervention. So lastly, have an amazing team. So that makes it really helpful to be able to interact with study participants and have them have a really positive experience. So really fortunate to have such a great team. So our website is brie.net if you want to learn more about any of our research studies. Usually my CV's on there and has all our references as well. So it's just a place that you can go get more information. So I'll wrap it up here and just say that I want to thank funding from NIH. And then again, if you're interested in joining our mobile weight loss study, go to mlifestudy.org. Thanks so much.
Great, thank you very much, Dr. Turner-McGrievy. So we'll open it for questions now, and please either raise your virtual hand or put it in the Q&A feature. We do already have a question for you And the question is, how well do you feel DPP materials and messaging are received by this population? Based on your experience implementing them, would you encourage further cultural adaptation for target audiences?
Yeah, there has not been a lot of cultural adaptation for DPP. Some studies have worked on that. We don't use a lot of it. We mainly use it as sort of a guide for the topic. So, DPP will talk about things like stress. And so for that, we'll bring in an African-American counselor who will talk about stress management. So we use it more as a guide versus the actual materials word for word.
Great, thank you. I was curious too about recruitment and retention, and I know you mentioned having an advisory board, especially with DG3D for that, but with New Soul as well. And you mentioned also, partnering with community partners, and that's so important. But given that for various reasons, including bad behavior on the part of the biomedical research complex, it can be harder to recruit folks into studies like this. So just curious, how was your recruitment? What strategies did you use? And then how was retention?
Yes, so we have a really good team that is very connected to the community. We have one person who is our recruitment and retention coordinator, so that's pretty much all she does. We have a paper out on our recruitment strategies for New Soul, if anyone's interested in that. We found that radio was actually one of our biggest recruitment tools, so we do lots of radio ads. So we've been pretty successful on recruitment. Retention, we've been good as well, getting, at least about 80% of participants to come back for assessments. So I will say the first New Soul study was 2 years, and that's just a really long time to keep participants in a study. People move, they take new jobs. We had someone join the Army, it's like lots of stuff happens in people's lives for across 2 years. I have seen a real shift since COVID with how participants want to attend in-person meetings. So there has been, when we do things via Zoom, participants say they want it in person, but then when we do it in person, so much stuff comes up in people's lives that they're like, I want a Zoom option. So I feel like more and more we're kind of headed towards almost a hybrid model where participants can do both options, because it just seems that that's more expected now, that people are very, used to being on Zoom and online. And so I'm sure that will hopefully help increase retention as well.
Great, thank you. And we have another question in the Q&A. When comparing the Mediterranean diet to vegetarian diets, how do you evaluate the similarities between the two? Is it mostly about no, some, or a lot of animal meat, and were there overlapping factors between these groups?
Yes, great question. So if you actually look at the food group recommendations that the U.S. Dietary Guidelines does for the Mediterranean diet, it is barely different from the healthy U.S. It's like a little less dairy and a little more fish, but there's not really an emphasis on the things that we consider a Mediterranean diet. So olive oil and lots of fish and healthy, fruits and vegetables. And so one of the things we did with our focus groups is we asked participants, we gave them sort of different food models outside of my plate for Mediterranean and vegetarian to get a more differentiation among those diets. So in terms of, so we're working on the focus group paper right now for the outcomes, but I will say, like, participants were most excited to get the Mediterranean diet. So they felt like that was new and different, but not so restrictive like what they thought a vegetarian diet would be. And they were probably most disappointed to get the healthy US because they felt like that's too familiar. I kind of know that diet. So participants we do teach it differently. All the recipes are different that we do among the 3 groups. So it may end up being sort of a, high, low no animal protein type diet, but I think it's a little more than that in terms of, the different food groups that are included in each of those diets.
Thank you. So another question I had, I know in my own studies, when I have weight loss as an outcome, unfortunately, I tend to have good results similar to what you showed, but looking more closely at it, often I find that there's a certain percentage of people who are doing really well and kind of driving the overall positive results. And then another percentage of people in the study who either maintained or even maybe gained a little bit of weight. I'm wondering if you saw something similar.
Yeah, I mean, we always see, we see people that are just losing lots of weight and doing really well, and then some that, gain a lot of weight. And I always, you worry about people who are in a study about weight loss that are actually gaining weight during that time period. What we present is always like adjusted for a lot of different things. And so you will see that sort of variation. I really wanted to get more away from weight loss as an outcome, just because I don't care about people's weight. I care about their health. And so to me, it's much more important seeing blood pressure go down and hemoglobin A1C go down. So that's one of the, things that's been really nice about these studies, is having some funding to be able to collect those measures, because those are really reinforcing. Even if the weight isn't coming down, if you see your blood pressure go down and you're going off medications, that's what's really important. So we're always glad that we're able to, we give each assessment time point, we give participants a personalized report so they can kind of see all the outcomes that we've measured and how they're, improving.
Yeah, I completely agree with that. I think it's good to get away from weight as a main outcome. And a lot of times you can see a lot of really meaningful outcomes otherwise, and not have to focus on weight.
Yeah.
All right, I guess one more question from me, as long as we don't have any others. Again, feel free to pop maybe one final question in the Q&A or raise your hand if you want. But in the meantime, I'm also interested, and it's great you're able to do a dissemination study of New Soul. Thinking from a kind of an equity perspective, in looking at REAIM, I'm always interested in REACH, and in learning like when an intervention maybe isn't reaching the people who need it the most. So I'm wondering what you looked at in terms of REACH, and if you have any early findings from that.
Yeah, so our main one, we don't have any yet because we haven't started the first cohort, but in our last one, that was one of the critiques one of the reviewers said, is that we were really trying to get participants from the neighborhood where the restaurant was, because it was a low income area, and that's really was what we were focusing on. But we got people from all over, and so our reach was kind of broad, but we really didn't want it to be so broad. So we implemented some additional strategies that we hope target the populations that we think are going to need the intervention the most. So we did targeted mailings, for an example, for certain zip codes that hopefully will get a population that needs it a little bit more. Related to that, one of the things we struggle with is, participants often want it online. Restaurant owners want it participants want it in person. Restaurant owners want it in person. But the online option really gets around a lot of barriers that, transportation issues, childcare issues. And so, again, that's one of the things that we very much struggle with like how to, deliver an intervention with high fidelity, but also address all those barriers that people face to attend weekly face-to-face meetings.
Sorry, I didn't unmute. So one final question in the Q&A. So what are common baseline attitudes towards the idea of plant-based eating?
I think we get a little bit of a biased sample because we tell participants you could be randomized to a plant-based diet, so they have to be willing to do that. I would say we have about a split reaction in the room when we announce. So we have participants come in, we reveal which group they're randomized to. Half the group is really excited and half the group is freaking out. They're like, oh, I didn't want this one. So I think it's really kind of split. And some people are sort of like, I'm up for the challenge. I've tried like Weight Watchers and I've tried like keto diets and I've, I really want to dive into this plant-based diet. It's something new. And others, one of the barriers we see over and over again is just family support. They may be up for it, but then they don't want, our participants don't want to make 2 separate meals for their family. Their family doesn't want to get on board. So we definitely work on bringing family members to meetings too, just so they can sort of get on board as well.
Great, and we're at time. Thank you so much again, Dr. Turner-McGrievy. Really enlightening talk, and really appreciated you being here with us today. Thank you.
Thanks so much.